Good morning, everybody. Today we are discussing about respiratory disease. In this topic, we are mostly concentrated on the dental aspect of the respiratory disease like asthma, COPD, TB, and how can we manage if there will be the respiratory disorders like asthma, TB, COPD like that. So first one we are going to concentrate asthma. Asthma is a chronic lung disease and that affects the airflow. The airflow is reversible and it involves difficulty in the breathing mainly due to the inflammations, mucus in the airways, and the tightening of the muscles around the airways. So, the trigger factors like air pollutants, pollens, animals, medications, foods. Mainly the medications like aspirin and anti-inflammatory drugs. And air pollutants such as like gases, fumes, aerosol agents, chemicals, anything. The symptoms we are showing in asthma patients like coughing, wheezing and whistling sound, shortness of breath, chest tightness, sneezing and running nose, itching and inflamed eyes. So it is showing us usually symptomatic with asthma at night and or during in the early morning hours. Bronchi and wheezing sounds can hear on the expiration time, and progress worsen during the asthma attack on bronchi and wheezing can occur in both inspiration and expiration phases. So the patients can use their accessory muscles on the respiration like a sternocleidomastoid and scalene muscles of the neck to assist with the breathing and oxygenation. So asthma is also associated with the paradoxical pulse, wherein the pulse increases during the expiration and decreases during inspiration. So next is on classification of asthma. It's like mild, moderate, and severe. In mild, that the duration is around less than 1 hour, and the severity of attack is less than 2 times per week. So what's the attacks follow the exercise or exposure to the trigger factors like uh, chemicals or aerosols or any other agents. So the main treatment for this type of mild cases we are using beta antagonists, and going for the moderate cases it will last for days, and if the attack is more than 2 times per day or week, activity will be restricted. In this case we will use beta antagonists plus steroids. Severe cases it may worsen, the duration will be more, the audible whistling sound also we can hear, tachypnea and sleep severity will be restricted. So in this case we'll give beta antagonist, steroids and theophylline also we can use. How will you diagnose an asthma patient? First one, the history of asthma attack and spirometry and allergic testing. So this type of case, how can we manage an asthma patient? First one, we will eliminate all the precipitating factors where possible, especially with the allergens. Means sometimes the patient is allergic to the chemicals or aerosols, anything, we will eliminate all the foreign bodies. Then implementation of the care by the patient immediately recognize the signs and symptoms of the asthma. It's mild cases we can directly we can give a beta agonist. If going to severe, we are going for the steroids like that. So medications immediately relief medications for long time control and prevention of asthma attacks. And asthma emergency treatment drugs also we can give. So the drugs like a beta antagonist, bronchodilators, methylxanthines, corticosteroids, uh, master cell stabilizer, leukotriene receptor antagonists, like that. So beta antagonists we have mostly we give salbutamol or terbutaline. Bronchodilators like ipratropine or oxytropine bromide. Methyl sanyl says theophylline. Corticosteroids we are giving beclomethasone or betamethasone or prednisone also we can give. Master stabilizer like netcomil, leukotriene receptor antagonists like montelukast, and other drugs like 5-lipogenase inhibitors like acetylmethane, like that. In oral manifestation, we have seen in anti-asthmatic drugs. We have seen we are giving beta agonists. The complication we can see is dryness of the mouth. If we're giving the corticosteroids, we can see steroid complication and adrenal crisis. So corticosteroid inhalers occasionally causes oral and pharyngeal thrush, can see, and angina also or hemorrhagia. Ipratropine bromide also leads to dry mouth. Leukotriene antagonist that leads to the bleeding tendency like INR value. International normalized ratio also will prolong due to impaired liver metabolism. Theophylline also level increased by epinephrine, erythromycin, clindamycin, azithromycin, and also ciprofloxacin. The inhaled corticosteroids are the most common long-term control medication that decrease the inflammation and airway swelling, especially for the mild case, moderate, and severe asthmatic patients. So it is generally safe and used for direct, but that also can lead to oral candidiasis on the roof of the mouth. So what we'll do to prevent the oral candidiasis in ask a patient to rinse their mouth with the mouthwash or any other uh, medication or this thing will use after the inhalation of bronchodilator or steroids. The guidelines we are giving for the asthmatic patients here. First, we will ask the patient about what trigger factors that can lead to asthma. Means if the patient having any uh, chemical allergens or aerosol that can trigger the asthma. First, we will ask the patient, and our 95% of attacks are stress related. So, give stress management for that type of patients. So, if the patient is having allergic or any other problem, we will avoid all these type of allergy things. If the patient is stress related, we will provide stress management. And the patient use puff of their bronchodilator prior to the treatment as an alternate for the stress management. So patient can take one puff before the treatment procedure. So particularly like ASA 3 and ASA 4 means American Society of Anesthesiologists, they categorize into 5 things. So 3 and 4 type of patient we are give the stress management. Confirm the medication used for the asthma management and have the patient bring their inhales to the dental office. So if you're going for the treatment for the extraction, inform to the patient bring their inhalers before the treatment starts. Evaluate the severity of the asthma. If suppose if the patient having severity is more means it is not a mild case or moderate case, no. So determine quickly and give the medications before, and it will reduce the risk. Next one is the drugs what we are giving prescribed for the patients. Like already I told that drugs like aspirin and anti-inflammatory drugs. So aspirin and SIDs, penicillins are frequently precipitate the allergies and also leads to asthma attacks. So Counter check whether the patient has used these medications before without any adverse reactions. Use these drugs only if they have caused no reaction. So, ask the patients if the patient having used before, like aspirin, NSAID, or penicillins before. If the patient having no any problems, then we can continue the medication. Otherwise, avoid all these medication and alternative drugs we can prescribe. Determine whether the patient has used oral or injectable corticosteroids for 2 weeks or longer in the past 2 years. You will follow the rule of twos for the major dental surgery in such patients. Rule of two, that means adrenocortical insufficiency may be suspected in a patient who have received glucocorticoids. So in this case, in a dose of 20 milligram or more of cortisone on its equivalent, or oral or parenteral steroids for 2 weeks or more than a week, or above 2 within 2 years of dental treatment. So what we'll do, the risk will be negligible, means non-surgical dental procedure we are going to perform. There is no need of the steroids. So we are going for a mild risk category, means minor oral surgical procedures like going for extractions or minor periodontal treatment like that. The regimens will give no glucocorticoid, means 25 milligram hydrocortisone or equivalent, means 5 milligram prednisone will give on the day of surgery. If the patient is going for a moderate risk category, so what we will do means like major excisions or impactions or periodontal therapy or going for a major surgical treatment under GA also. It will last for more than an hour. What we'll do, the steroid like 50 to 100 milligram per day or prednisone equivalent the day, one day before the surgery and one post-op that day. So it is very important, otherwise the risk will be more. Next one is chronic obstructive pulmonary disease. COPD is mostly seen on the uh, smokers. It's a chronic, slowly progressive, and irreversible disease characterized by breathlessness and wheezing. So we can see like the symptoms like cough, breathlessness, edema, morning headaches, like that. The clinical features mostly seen non-specific and correlate poorly with the lung function. Present only in advanced disease. The breath sounds are typically quiet. Crackles may be accompanying infection, but it presents raise the possibility of the bronchiolitis. Edema usually relates to the failure of the salt or water excretion by hypoxic and hypogamic kidney. So, in dental aspects, they are classified into three: low risk, moderate, and high risk. Low risk means experience dyspnea, difficulty breathing on the effort, but their normal blood gas levels will be normal K, means the oxygen value and carbon dioxide. Can receive all the dental treatment with a minor modification. So this type of patients we can go for the dental treatment because the risk factors will be less. If the patient having moderate risk, so what we'll do, experience their dyspnea with the effort, chronically treated with the bronchodilators or recently with their steroids. So their partial pressure oxygen will be lower. Medical consultation is advised for this type of case because the patient is taking bronchodilator and also they are taking steroids and more their oxygen value will be pressure of the oxygen will be less, so we'll advise medical consultation. If you're going for a high risk, have symptom of COPD that may be end stage and poorly responds to the treatment, so medical consultation is essential for this case. So we can never touch these type of cases with the high risk patients. So suppose if we will get the opinion everything, what are the main things we'll do for this type of patient? First, we'll treat it at mid morning or uh, early afternoon with the upright in position. Never put in a supine position. And if the patient is going for a root canal treatment, so rubber dam will be contraindicated because the patient having difficulty in the breathing, because sometimes the patient is a mouth breather and are unable to tolerate the obstruction in the mouth. And GA is not preferred for this type of cases, only LA. And don't give bilateral mandibular or palatal injection. And the relative analgesia should be given only absolutely if necessary. Respiratory infections must be eradicated. Suppose if the patient having severe respiratory problems is there, no? So avoid all this type of cases. Contraindicated drugs like diazepam, midazolam, and IV barbiturates. Drug interactions with theophylline, epinephrine, erythromycin, clindamycin, ciprofloxacin also. Corticosteroids with the precaution means we can never give a long-term corticosteroid because already we mentioned the patient having high risk cases, there will be chances of complication will be more. The infections you can see on the COPD patients like normally lower respiratory tract infections mainly by laryngotracheobronchitis, acute bronchiolitis, acute bronchitis, acute pneumonitis. So, laryngobronchiolitis are the viruses or microorganisms seen in mostly by influenza virus or mycoplasma or respiratory syncytial virus. Acute by influenza virus or respiratory syncytial virus. Acute bronchitis cases were seen in night adenovirus, coronavirus, Coxsackie virus, influenza virus, rhinovirus, mycoplasma pneumonia like that. Acute pneumonia is in Escherichia coli, then Klebsiella species, Pseudomonas aeruginosa, SARS, Streptococcus pneumonia like that. So the main causes of pneumonia cases by inhalation, aspiration, and homogeneous continuous spread or reactivation. Inhalation by the organism inhaled by like a Streptococcus pneumoniae, Streptococcus pyogenes, Mycobacteria, Legionella, and measles virus, adenovirus, histoplasma, like that. Aspiration by Streptococcus pneumoniae, Staphylococcus aureus, and Gram-negative bacilli. Hematological organs like Staphylococcus aureus, plus Gram-negative bacilli. Continuous spread by anaerobic Gram-negative bacilli. Reactivation by Mycobacteria, then histoplasma, blastomyces, toxoplasma like that. So the dental aspect we can see majority the severe illness and the dental treatment should be contraindicated except for the emergency dental treatment. And GA hazards here absolutely contraindicated. Dental treatment should be deferred until the recovery or the limit of being released. So the mainly the pneumonia cases what we are seeing in the elderly patients and those who are having chronically ill cases and patient having viral infections. Sometimes the patient is a smokers or immunocompromised patients like that. So the symptoms, so we can see in this type of pneumonia cases, fever will be there, difficulty breathing, increase the pulse, mucus cough, and bluish skin. Next one is tuberculosis. Tuberculosis is a condition in which the tuberculosis may become activated, like recent infection or in young age, HIV or immunosuppression, alcohol or drug abuse, cancer, chronic kidney failure case, diabetes, gastric bypass, leukemia, silicosis. Mainly we are seeing in like in HIV cases or recurrent infection cases like that. So, uh, in tuberculosis patients, the main thing is if we are taking a history, or if suppose the patient have a history of TB, that acute sputum will be positive, the risk will be high. So what we'll do is urgent treatment, means like emergency treatment only we can do. Use special infection control precautions, mean infection control will be necessary other than the other treatments. So deputy elective dental care until the TB treatment is complete. Means if the patient having TB, so emergency treatment only do. Other things will control the TB. Suppose the recent history of TB and sputum will be positive. So it's also same thing, high risk, and the treatment protocol only the emergency treatment. If the patient have the past history of TB and non-history of TB, but the signs and symptoms suggestive non-history of TB but positive tuberculosis test. So in this step, mostly if the patient in early childhood, the patient have TB, after that it's become normal. In this case, we will refer to the physician. We want to confirm about the risk. It's a mild, moderate like that. If it's after the confirmation, use the special infection control precaution will do only for the emergency dental care, and defer elective dental care until the medical advice received. So suppose if the patient you have a severe toothache, and the same thing like past history of TB is there, and history of TB like that. So emergency treatment only will do for that patient. After the treatment, like other treatment procedures will do when we get the physician opinion. Then only we can complete the dental treatment. So in this topic, we are discussing about the asthma patients, COPD, pneumonia, and also tuberculosis. But mostly we are seeing like asthma, COPD, and TB. Thank you.